Right, hello everybody, we're going to get started. Welcome along to this evening's Abertay Historical Society talk. This evening we are delighted to welcome Professor Nicol Ferrier. Professor Ferrier studied medicine at Newcastle University and then trained in psychiatry in London. He moved to Newcastle in 1984 and in 1990 was appointed Professor of Psychiatry there. He specialised in studying the causes and treatment of severe mood disorders. In 2016, after his retirement, he embarked on a part-time PhD in the history of medicine and he graduated last year. His subject of study was mortality in Victorian asylums. One of the asylums studied was the one in Montrose, which we will hear more about now. So I will pass over to Professor Ferrier and we can get started. Thank you.
Thank you very much and good evening. And thank you very much for the invitation. So when I was invited by Matthew, it turned out the most suitable date was February the 14th. So I had to say to him, I don't think this talk will be very romantic. It's about asylums and death and things like that. And he said, well, it'd be a good antidote to Valentine's Day. So that's what I'm living up to. That's what to expect, an antidote to Valentine's Day. So thank you. I'm Nicol Ferrier. I was a psychiatrist and I retired in 2016 and I decided I wanted to study history, which was my first love, and do a postgraduate degree. And then I discovered, in fact, if you want to study history, you have to have an undergraduate degree in history. And I really didn't fancy doing that, particularly in the early mornings and exams and things like that. So it turns out you can do a postgraduate degree in the history of medicine with a medical degree. So I was able to, so I'm not a historian, that's a sort of health warning I'm doing at the start. I've come really through the back door. So I've studied the history of medicine, which, as I say, you can do without a history degree, with just a medical degree. But I was very fortunate to meet a chap called Dr. Jonathan Andrews in Newcastle. He'd been in Newcastle most of the time I had been there, but I never knew he was there. And he turned out to be an expert, a real expert in the history of psychiatry. So we had a chat, and during the chat he mentioned this particular project to me, and it appealed to me because it kind of linked a little bit to what I had been doing in my professional life, but it also was an opportunity for a doctor, a doctor, to look at some records that had not been looked at before, and so there were medical records and to look at them from a medical standpoint. So that's my start of my project. I'll tell you a little bit more about my project as we go on, the detail of it. But what I was studying was studying asylums in the Victorian period of time, the late Victorian period, and one of the asylums I was studying turned out to be Sunnyside Asylum in Montrose Royal Asylum as it became. And so I want to start with talking a little bit about that asylum and some of the interesting history of that asylum, and then introduce a little bit more, this will provide a context when I come to introduce my actual project in a bit more detail, because Sunnyside really is a fantastic place, and really very interesting from all sorts of aspects, but really quite unique in the history of psychiatry. So this is a picture of the person who really drove the development of Sunnyside, was Susan Carnegie. And she was born just before the Jacobite Revolution. She was born in 1743, and she was born into a very wealthy family in Edinburgh. Her father was treasurer of the Bank of Scotland, so that's fairly high up. And she lived in the Royal Mile, and she had a very interesting upbringing. She was brought up at the time of the of the Scottish Enlightenment in Edinburgh. And David Hume was more or less a next door neighbour. She rubbed shoulders with all these people. And of course, being a lady in those days, she really didn't get much in the way of formal education, but she was very determined to educate herself. She was very driven to educate herself, and she had really two drives. One was to educate herself, and she learned all about science and humanities and philosophy from the people who lived nearby, but also she had very strong humanitarian instincts, so which we'll come on to in a second. So it was very interesting. Her father, being treasurer of the Bank of Scotland, there is a story that post the Jacobite Revolution in 1745, there was a kind of insurrection. Some Highland chiefs threatened to march in Edinburgh, and her father took all the money from the Bank of Scotland and took it to their homes. So at one point, all the money in Scotland was in her house. Whether that story is true or not, I don't know. It may be a made-up story to cover some bad practice or something. I don't know. Anyway, so Susan, when she was 26, married a chap called George Carnegie, and he was also an interesting backstory. George was a Jacobite, and he had been at Culloden, and he'd just escaped. And then he was a fugitive around the north of Scotland for a couple of years, living in disguise apparently, before he went to Sweden, where he actually made quite a lot of money. And then he returned to Montrose, where his family had property, and he married Susan, and she moved therefore to Montrose, and she got very much involved in humanitarian things when she arrived. She, for example, set up the first lifeboat in the town, and at that time there were lots of deaths at sea and terrible tragedies, and she also did a lot for the children of Montrose, which was very exercised about the treatment of people with mental illness. And at that time, if you had what was called furious mania, you were difficult to control, what happened you were locked up in the toll booth. And this is a picture of the High Street in Montrose as it was then, and the toll booth just underneath the church there. It was this building, effectively a jail, and Ventolero were taken in with the common criminals. And it was open to the public. The public could walk by and often threw things at the mentally ill, who were often chained up, and she became extremely exercised about this. So she determined that she should raise some money to build an asylum where proper care and humanity could be exercised. And she said she wanted to rid the town of Montrose of a nuisance of mad people being kept in a prison in the middle of the street, and hoped that by providing a quiet and convenient asylum for them, by good treatment and medical aid, some of these unfortunates might be restored to society. So she had a kind of also a realistic vision. She only said some of them. She realised something of the difficulty of mental illness. So she started to raise money, and she had to liaise with the Montrose Town Council and the parish kirk and so on and so forth, but was very effective. She was very forceful, and did achieve all the money to build an asylum on the outskirts of Montrose. I should say she did all this between having had her 5th and 6th child, so she was really quite a dynamic lady. And this is the asylum that was built in 1781. It's on the links at Montrose, just down on the sort of peninsula, and at that point there was a whaling terminal, whaling harbour there, which was very busy. This was built beside it, but it was characteristically, she liked it was very quiet, and it was out of the sort of normal passage of people, and it's where she felt people with mental illness could get better. And it from the start, it practiced very much humane techniques, and what she encouraged the patients to do was to get involved in the care of the animals. It was effectively a small holding, and it achieved quite a lot of prominence. It was, I should say, really the first psychiatric hospital in Scotland, and pretty much the first one in the world, really. There were other ones, but this one was a formal psychiatric asylum created in 1781, so it has a claim to be really the first asylum in the world. So quite a remarkable thing that she did, and she did it so well that in 1810 it was granted a royal charter, so it became the Montrose Royal Asylum in 1810. It became enlarged many times. It was because of the increasing numbers of people. There's a whole story about why increased numbers of people with mental illness finished up in asylums, which I don't have time to go into, but there was a lot of pressure to admit people to asylums at this period of time, and this was no different. So it enlarged, and then eventually it couldn't enlarge. The other problem was that the whaling harbour was going full blast, and it was getting very noisy, so it was decided in 1758 to move asylums to the one we know now. But Susan's influence was really very strong, and one of the things she said, I think in that original quote, was that she wanted someone medical to be involved. Medical people had not been involved in asylum care at this time. And in fact, she died in 1821, but she would have been absolutely delighted that her efforts to get a medical man involved bore fruit by the appointment of the first physician superintendent in 1834. And he was this remarkable man, Dr. W.A.F. Brown, who's always known as WAF. And he was a chap, he trained in Edinburgh as a doctor, but then he'd worked in Paris with Esquirol, and Esquirol was a social reformer who'd also worked with a chap called Pinel, who was famous in psychiatry for unchaining the mentally ill and showing that when they were unchained, they did well, they did better. So Esquirol had learned all this from Pinel, and then Brown went to Paris and learned from Esquirol. So he was appointed as physician superintendent in Montrose in 1834 when he was only 29, but he was really very dynamic, bright chap. And one of the things he did when he arrived after that, and shortly after that, was to give a series of 5 lectures to the trustees of the asylum, and it was entitled What Asylums Were and What They Ought to Be. And it became a very famous, it was then the 5 lectures were put together and published in this publication, became quite famous, as a sort of template for good asylum care of how it should be organised, both in Scotland but also nationally. He achieved a lot of prominence. Unfortunately, in 1838, Susan Crichton was, Churchwoman Crichton was developing the Crichton Royal in Dumfries, and effectively he was what we now call headhunted and left Dumfries. He left it at Montrose in 1838 to set up the Crichton Royal Asylum, which itself was a very famous asylum. He then became a commissioner in lunacy for Scotland, sort of in charge of reviewing and assessing asylum care, and he came back to Montrose and gave it quite a positive outlook. So he was an early advocate of non-restraint, of people who did better if they weren't enclosed, of occupational therapy, as we call it now, and of self-expression. He encouraged all the patients to involved in art. So, as I mentioned, the asylum then moved to Sunnyside. This building was built in a place called Hillside, just outside Montrose, and was opened for admission in 1858, and eventually it was open until 2011. So if you take from the start of one of the links in Montrose to the 2011, this is the longest psychiatric institution in Scotland, or indeed in the UK, possibly in the world, for continuous psychiatric care. It was a remarkable place, and many of you may have visited it or seen where it is, but it sort of sits on a hill and becomes very dominant sort of place. But within there was a lot of good things happen, and I'll focus on them for a moment. There was a farm at the back of the asylum, and patients were encouraged to work in there, and they lived on their own produce a lot of times. The diet was very, very healthy. A lot of activities took place. There were concerts and balls and exhibitions and dances, lectures from visiting speakers, and all sorts of things were going on in Sunnyside. It was tremendously active, and the whole principles that had been laid down first by Susan Carnegie and then by W.A.F. Brown of non-restraint became very much the way things should be. So a tremendous achievement, really, and it received a lot of positive reports. This actual picture, though, actually shows an even too idealised picture, a view of it, because there's ladies here chatting under the tree, and there's someone reading a book under there and strolling around with their parasol. And in fact, this is actually an advert, effectively, an advert for their private wing. It's a bit like a Bupa advert you see in television now. There's lots of lovely machines and people with lovely white teeth. You know, it's an idealised picture of it. But it did have a private wing, which is this right-hand part of the building here, and that, of course, helped to fund the rest of the asylum, and the rest of the asylum was a pauper asylum, which meant that if you couldn't afford to pay for it, that's where you went. So you went to the pauper side, which was over here on the left. This building here was housed many famous private patients. And it's now, since the hospital closed in 2011, I visited the site about 4 or 5 years ago, and it's going to be turned by the developers into a luxury hotel, which is quite an interesting outcome for it. One of the interesting patients that was in this private wing was this fellow here, who was called Charles Doyle, and he's in fact the father of Conan Doyle. And Charles Doyle was a famous illustrator in Edinburgh, and he was a very, very good artist. The whole family were very artistic, and Charles really produced some wonderful work. But unfortunately, he then started to drink to excess and couldn't control it, and became extremely unwell. He actually had delirium tremens a number of times. So he was admitted to the private wing, which is seen behind here. And this is a fantasy picture of ghosts and spirits over the outside of Sunnyside Asylum occurring, which appears in a book about him called The Doyle Diary. But Conan Doyle, although he found his father very frustrating, dealing with this alcoholism, which was really eventually killed him, he went to Crown Royal actually after this and then died, unable to control his alcohol. And Conan Doyle actually got his father, even in his latter years, to illustrate quite a number of his first editions of Sherlock Holmes books, including the Study in Scarlet. So that was one of the famous patients, private patients, Charles Doyle, in the private wing at Sunnyside. But during this time, the physician superintendent was Dr. James Howden, and he's a remarkable chap. I'd just like to spend a few minutes just talking about him. So James Howden was appointed physician superintendent in 1858 at the very opening of the asylum. So the whole asylum for the next 40 years of his tenure in that position was forged in his name, and he put his stamp on it. He had also trained in Edinburgh, but he'd taken a different route to Brown, and he'd become very interested in brain research. So he published a number of papers on the brain in mental illness. And this time the whole idea of looking in the brain for the seat of mental illness and the cause of mental illness became really a major thing. And he was very much involved in the beginning of that and published on the brain and mental illness, and got his MD from Edinburgh. So he's appointed to Montrose and very keen to keep up the same idea of research going on. And during his time in Montrose, he published an atlas on the normal and lunatic brain to help people who were then going to study the brain and dissect the brain to do it in a proper manner. And he published this, although there wasn't much evidence that was widely taken up. But in addition to these interests in more biomedical or hard science of mental illness, he was also an advocate of non-restraint. And the things that had been created in the previous asylum continued under him, all the activities and the idea of patients having a humane approach and lots of activities and exercise was very much that of Dr. James Howden as well. And he stayed in post until he was replaced in 1898. So, I mentioned earlier that this picture that you see here is an idyllicized picture to reflect how wonderful the Sunnyside Asylum was. But of course, that wasn't the whole picture. There were lots of problems in asylums all over the UK and elsewhere, great difficulties. And one of the main problems was overcrowding. These places were vastly overcrowded. Great pressure on beds, so there was enormous numbers of patients coming in. And of course they had no treatments, and they began to find it quite difficult to keep up all this forceful occupational therapy. So that went a bit by the wayside. But there was also quite a lot of violence here and fights and difficulties that you imagine dealing with a lot of untreated patients with severe mental illness. There were problems, and indeed there were lots of so there were violent outbreaks and so on. And there was also a lot of death, and death occurred quite frequently in Sunnyside Asylum, as I'll show, but this was a pattern that was happening elsewhere. And it's that area that I want to study, which was my project was about, studying this particular area. So mortality and insanity was a real problem then, and in fact remains so now. So in the 19th century, the commissioners on lunacy got very concerned about the continued high death rate that was occurring in asylums. When asylums were developed, one of the ideas was that it would actually stop this premature death toll, that the death toll was something to do with the fact they weren't being looked after properly. If they were brought into an asylum and cared for, given a humane approach and a medical sort of involvement, then things would be better. But things weren't better. The death rate continued to be very high. So in 1870, the commissioners in lunacy in England and in Scotland recommended that post-mortems be performed on all the patients who died. Now some alienists, as they were called, and psychiatrists were called alienists then, demurred and said this was a waste of time. But in fact, by the end of the 19th century, huge numbers of postmortems were being performed in asylums. So Jonathan Andrews, who I mentioned earlier, my supervisor, mentioned this to me and mentioned that no one had actually looked at these postmortem reports. So I decided that would be quite an interesting project for me, and that's how I got involved. Now, the key driver of this postmortem, the idea behind the commission, was to provide oversight of this asylum mortality. It was thought that these deaths were suspicious, they had been caused by lack of care or by violence. And the idea was that if you could identify that at post-mortem and show there had been lack of care or direct violence, then you would be able to prevent that happening. So that was the idea, the principal driver behind this. It was really the idea that you needed oversight to try and get a handle on this problem. But there was this other influence going on at the same time, and that was that you should research in the brain and insanity. There was increasing interest in that area. So the Commissioners of Lunacy also saw this as an opportunity for lots of research and lots of discovery of what was going on in the brain in these very disturbed patients that they were looking after. And there was reasons to be optimistic, because around this time, when I talk about the late Victorian period, some promising developments had happened. And there's a condition called GPI, general paralysis of the insane, which is a very disturbing neuropsychiatric problem. Lots of problems with movement disorder, but also problems with dementia. And it was shown quite clearly that the pathology of general paralysis of the insane was caused by syphilis, and they were able to identify this was due to syphilis. So it was a really remarkable piece of work. But quite clearly, these people with this particular clinical characteristic, this particular change in their brains at death, had syphilis. Now, they weren't able to treat syphilis in those days, but they were able to at least identify one cause or one part of all this problems in the asylum. And the other development around this time was nobody was Alzheimer's. So Alzheimer in Munich had identified people with dementia, with major memory problems and changes in their brain, and he was able to link the two together. So again, this was very exciting, that something happening to someone mentally could be explained by some changes in the brain. So all of this led to prospects of an understanding insanity seeming bright. So these were the two drivers that led to all these postmortems being done. So this is my project, a study of postmortems in two semi-rural asylums at the turn of the 19th century. And I studied two asylums, Sunnyside, as was mentioned, but also the asylum, so-called Fairmile Asylum, which is now in Oxfordshire, but then was in Berkshire, so it was called the Berks Asylum, interestingly. And it's by the banks of the Thames, and it's also had a very illustrious career in psychiatry, now closed, and now a housing estate for rather nice houses. So they also carried out a lot of postmortems, under actually a Scottish physician superintendent, as did Montrose. So that's the reason I studied these two. And there were an interesting comparison between the two, because there were differences and also a lot of similarities. So that's why I studied these particular two. But tonight I'm going to focus on the results and the findings from Sunnyside on the right there. So this involved, the bit in Sunnyside involved going into the NHS Tayside archives. So the archives, fortunately for when Sunnyside closed in 2011, were carefully brought together and brought to the NHS archive in Tayside, and then to sort of rescue some of them too. They're stored in the basement. Probably many of you may have been there, in the basement of the tower block at Dundee University. So I'm very much in the basement here. So I spent a long number of hours, many hours, in the basement of the tower there, looking at case books, looking at all the case records, which were written out in longhand, very long and tedious. The registers of admissions and death, to get some idea of the numbers and how many were dying, and all the post-mortem reports of the patients of interest. And these called minute books, which were kind of records of all the meetings they held by the management and so on. So it was quite very hard work, but it was enlivened by various things. One was meeting my cousin and her husband for lunch every now and then, so they're nice to meet them in the audience tonight. So coming. The second was it was a wonderful cafe at the top here. Maybe some of you know it, but I can highly recommend it. Wonderful views and lovely rolls, very good. And the third one was the staff of the archive here. So Dr. Jan Merchant, Dr. Kenneth Baxter and Sharon Kelly, and they kept me sane and enlivened the proceedings. They were extraordinarily efficient, but also very, very helpful. So I wanted to pay tribute and thanks to them. Unfortunately, none of them can be here tonight. So I went through all the records of people who died and their post-mortems to try and piece together the pattern of what was happening and why these patients were dying and dying at a relatively young age, as I'll show. So here are for the period I was looking at, between 1892 to 1901, when I had particularly good records on all these different aspects of the condition. So in blue are the deaths. So there were 50 deaths in 1892 and 70 odd deaths in 1901. And essentially the reason behind that was greater numbers. So there were about 500 patients in Sunnyside in 1892, but under great pressure, you had to increase the numbers to about 700. The death rate was about 10%. So I mean, every year, 10% of the asylum population were dying. And so that is much higher than you would expect in the normal population. You know, one has to say that. You know, that death rate is high. Now the postmortems are in red, so you can see in the initial phase, postmortems were really quite a high percentage. There were about 70% or 80% of the people who died had a postmortem, as had been laid down by the commissioners of lunacy that all patients dying should have a postmortem. So they achieved about somewhere between 70 and 80%. And this was very much when Dr. Howden was the physician superintendent. He drove this and made sure that it happened. Then he retired in 1898, and you can see the postmortem rate fell off because Dr. John Havelock, who then took over, who had many strengths, he was interested in treatments. He wasn't so interested in postmortems, so the numbers fell off. So what I've been looking at is all these patients who had postmortems. The postmortems were actually carried out on site in a mortuary at the top corner of Sunnyside. Mortuaries are always found at the perimeter of hospitals. And this is the actual mortuary. I saw this on my visit about 4 or 5 years ago. The patients were brought in, I told you this was an antidote to Valentine's Day. The patients were brought in at the top, and the dissection took place here. Then they were brought down to the bottom bit where there was a chapel of rest and where visitors and relatives could pick the body up, and then they were taken off for burial. Now, in fact, many of these patients were paupers, and in fact they had a pauper funeral in a proper grave, and no relatives were coming to bury them. I'm not quite sure how many, but roughly 60 or 70% had a pauper funeral, which I think was in a place in Montrose called Sleepy Hillock. But I'm not certain about all of that. So that was where these postmortems were carried out. The postmortems were actually carried out by staff psychiatrists. So this is me now as a psychiatrist and an ex-psychiatrist, and I do a postmortem. Completely, awful. But in those days, medical doctors were trained a lot in anatomy and pathology. We didn't have all the modern disciplines that we have now, biochemistry and radiology and all these things. Pathology and anatomy were the two kind of main cornerstones of teaching in the universities. And the Scottish universities, both Glasgow and Edinburgh and other universities, were very strong on pathology and anatomy. They were centres of excellence, really. So the doctors who were involved had actually been well trained as students to do this. And then when they became doctors, there were numerous manuals and atlases for them to understand the complexities of the brain. Now, the postmortems I've actually examined are actually really quite high standard. Sometimes difficult to read because of the handwriting, but the actual standard of them is pretty high. I actually had them checked out by a friend of mine, a professor of pathology in Glasgow, Professor Alan Fowlis, who's also a great friend of my cousin here. And he thought they were well done, and there were no appropriate use of terms. So although they're done by psychiatrists, I think they've had some sort of quality threshold. As I mentioned before, it was described as a duty to carry out post-mortems in all cases, which raises the issue of what happens about consent. And it's pretty clear that unless there was a direct contesting, unless there was some objection raised by relatives, a post-mortem was carried out. They didn't seek active consent. It was only if someone didn't object that it was not done. So, slightly, we'd be slightly concerned about that nowadays. But that was the situation then. So, those people did post-mortems. So then we begin to look down at the actual data I found. So the first thing is about the age of death of the inmates. Now, what I selected to study were two groups of patients, patients with so-called mania and so-called melancholia. These were in fact the two diagnoses that patients with what we now call severe mental illness were given. And it's a long sort of story to work out exactly what they were, and it's a difficult thing to do and perhaps a wrong thing to do to try and diagnose patients from the past. So I just took these terms at face value. But broadly speaking, melancholia would be what we would now consider to be severe clinical depression, patients who have become extremely depressed, unable to eat or drink very much, not interested in things, very slowed down and so on. And there's a lot of very good descriptions of that sort of patient in the population. Mania, on the other hand, was probably a mixture of people with what we now call bipolar mania, who were high, and people who had psychotic illness, what we now call schizophrenia. That was a mixture of the two. So I studied those two and excluded patients who had more complex neurological disorders, general paralysis of the same, dementias, and so on. I excluded them. I looked at patients with mental illness. So that's the group I've studied here. So here's the death distribution, age of death of this population. So in blue is the manic patients. And you can see, on the right here, there are patients dying at ages we might sort of expect, in the 60s and the 70s. But there are also a whole lot of patients who are dying in their 40s, 30s, 20s, and even in their teenage years with psychotic illness. In melancholia, the picture is roughly the same. So there's again patients dying at a more sort of age one might consider to be normal, but lots dying in these early ages. And severe melancholia was really quite a very difficult condition with no treatments for it, of course. So patients often died, failed, succumbed to death because they were unable to look after themselves and they were unable to help them with this problem. So so the average age of death turned out to be roughly in the mid-50s for both groups, 54 and 55. So I took that to age 55. So the first thing, one of the things I did with this is to look at how this compared with the general population of the time. So this is again in the late Victorian time. And that's quite a difficult thing to do for various reasons, one of which is that infant mortality was still very high. So the actual average age of death was actually relatively young if you included infant mortality. It was still occurring. There were still fevers, gastroenteritis, all sorts of things, taking away very young children, often in deprived areas particularly. But if you survived infancy and got to adolescence, then the average longevity of patients, of people in this part of Scotland at that time was about 67, so somewhere in here. So what we see here is evidence of what I would call a mortality gap. So my patients were dying around the average age of 55, which was younger than those other patients who had survived adolescence, which was about 67. So a mortality gap, and I'll return to the mortality gap in a moment. So what I decided to do was to look at the deaths of all the people who died under the age of 55, to look at that young cohort. You wouldn't be expecting death. Why did these people die? Was the question I was asking. And I didn't look so much at the people who had died over that age. So I'm looking at the age of under 55. It turns out that my finding was not unique. This is some data from Toronto, which was very much part of the British Empire at that time and had British sort of asylums developed. And this is the age of death of people with mental illness in those asylums. So going back to 1861, they were actually dying on average in the mid-30s, and that improved over the period of 30 years to get to the mid-40s. But if you look at the normal population, also had a similar improvement in longevity over that period, but there was still this gap here, which in this grouping was about 12 to 13 years of difference. And this was a very well matched population. The actual finite ages are different, but they're matching samples they put into it were slightly different from mine. So other evidence of that mortality gap, our patients, my patients with severe mental illness, are dying young, dying prematurely, and dying under the age of 50, which we wouldn't be expecting in this population. So why did the patients die? What was the cause of death? So I've gone through the post-mortem reports of some detail. And this is the detail from the both asylums I looked at, but the Sunnyside ones I'll point out as we go through. So the main cause of death was infections. So I've divided them into tuberculosis, pneumonia, and GI infections and gastrointestinal infections. So in total, about 60% of the patients died. So 3/5 of the patients died of infections. And you can see that the biggest death was tuberculosis. So the death rate from tuberculosis overall was about 38–40%. So tuberculosis at that time was a disorder, a disease of the young. It caused mortality in the very young, often men and women in their 20s would succumb to tuberculosis. One of the questions is whether these patients had tuberculosis before they came into the asylum or whether they got it in the asylum. And it seems that it's a mixture of both. Some were definitely admitted with it, I think. I'm pretty certain they were admitted with it. Others seemed to get it. And of course, it was a very closed, crowded environment. And although the food was good and so on, it was still very, very closed. We were in major, large wards, sleeping cheek by jowl. So you can see how that would be a breeding ground for tuberculosis. The death rate in Montrose was even higher, at 42% dying of tuberculosis. And these were often very young men working in industry or in the fishing industry in particular. Then there were patients dying of pneumonia, about 16% died of pneumonia, and then gastrointestinal infections. And here was a good tick for Sunnyside, because all the gastrointestinal infections were in the other asylum in Oxfordshire by the banks of the Thames, where they had major problems with sanitation. The water in Sunnyside, they may have had a lot of problems in Sunnyside, but the water was perfect, and they had no infections at all. There was nobody getting infections, and certainly no one died of it in Sunnyside. So that figures all the way up from the other asylum. Then some people died of what I've called surgical deaths, and these were people who died of things like twisted bowels, appendicitis, perforated ulcers, and some cancers. And what's interesting about them, relatively small percentages, that even then, if these people had been in a general hospital, they would have probably been treated. Surgery would have helped them. But surgery wasn't available in Sunnyside. There was really no liaison between medical services and psychiatric services. Suicide was actually very rare. There were 2 cases that died of suicide who went to enormous lengths to kill themselves. Sorry to say this, I won't go into too many details. Suicide was considered a very black mark for an asylum. If it had suicides, this was considered, but now you have these care quality commissions come and look at places. Suicide was a very black mark even then. And so they went to enormous lengths to prevent suicide, but 2 patients managed to escape those enormous lengths and kill themselves. But what was interesting in this young population, the average age of death in this population was 43, was there was really quite a lot of vascular disease. People were dying of heart failure, apoplexy, which is stroke, and fatty heart. And I'll mention fatty heart a bit more detail just in a second, but it's to do with what we now call ischemic heart disease causes fatty heart. And about 1/6 of the patients died of heart problems. Some had problems in their brain, which were seen to be the cause of death, and that's a bit uncertain. And some died of exhaustion. Remember, there was no treatments. These patients were very overactive, restless, couldn't be contained, didn't sleep, and eventually about 10% of them died of just sheer exhaustion. but they were interesting in their own right, as I'll mention in a moment. So those were the causes of death of this population. What was very, very not found was violence. There was no real evidence of any violence occurring to these patients in the way the commissions of Lucy thought there might be. There was no evidence of violence, except in one case, which I'll just mention briefly in a moment. So there were some interesting things in this. And what was also interesting, when I looked at the whole population who died but didn't have tuberculosis, I then looked at the hearts and vessels, the reports about hearts and vessels of those patients. Remember, they were all around age 40. And what we find is that ventricular hypertrophy, which is enlarged heart, was found in about a third. The myocardium was soft, flabby, and fatty. And this is due to ischemic changes, was in nearly half. Half of them had atheroma in their cardiac vessels, and half of them had atheroma in vessels in either the heart or the brain. So those patients, these people who you might think were young and fit and so on, you now think of atheroma as a cause of disease and death in the elderly, was actually present in these younger patients who died. So some evidence that cardiac disease across the board was really quite common in this population. And that's perhaps why they were succumbing so early. So this is a fatty heart. It was described by a man called Sir Richard Quain, who was a remarkable man. He was Irish. He worked in London. He became surgeon to the Queen. He was quite a chap. And he also did a lot of pathology. And he looked in the heart of people who died young and found fatty degeneration, and described the myocardium, that's the muscle around the heart, is transformed into soft, yellow, fatty tissue, which presents a pale, dirty yellow tint. And that exact description was mimicked in these post-mortem reports in Sunnyside. Now, he noted that the coronary artery, which supplies blood to the heart, was ossified, was hardened in these patients, but he didn't link the two. And really, there wasn't much linking of the two down until really quite a lot later. But interestingly, on this, using his particular sample, this pathologist who worked in Aberdeen looked at the samples that Quain had described, because they'd been preserved in formalin, and was able to show that the group of patients that had this fatty heart had ischemic heart disease. So they were dying of this condition called fatty heart. Some of them had what we now call myocardial infarction, heart attacks, but relatively few of them. Most of them had this disorder of fatty heart, and that's why they died. Myocardial infarction only became really a big problem when smoking became common. Because that's really the cause of myocardial infarction, atheroma plus smoking. The other patients seemed to die of this condition, fatty heart. And it was found that about 40% of the patients I looked at under the age of 40. So let's just sort of recap and summarise. The postmortems were carried out to monitor and reduce violence, but did they do that? Did they contribute? All these postmortems done all over the UK, huge numbers. And I don't really think they did. I mean, there were reports of maltreatment and violence in asylums across the 19th century, but they generally fell across the period. But whether the fact that postmortems were being done contributed to that, I think is not difficult, not easy to say. And definitely the death rate didn't change. There is a little caveat about that, so, because there were a couple of cases, not in Sunnyside, but in the other place, where there may have been some violence, but it was actually covered up in the post-mortem. So the post-mortem noted the changes of the violence and learned about the violence in the case report, but didn't really make much of it and didn't call it a cause of death. So there might have been a little collusion going on in the odd case to cover up and to protect the staff. Of course, post-mortems have an aura about them that can tell the truth, so maybe that did stop some of the violence happening that was causing death, but I don't really think so. So they didn't really work. The violence fell anyway. The death rate remained the same because it wasn't due to violence in the first place. What about the other objective of the post-mortems? This was to ascertain the cause of death and clarify the pathology of asylum. But there's in fact little evidence that these post-mortems were used as teaching material or were disseminated widely. But they were part of a sort of developing interest, a scientific interest in mental illness, so they may have engendered hope. These were pretty hopeless places, these asylums. You couldn't do anything to help people, so the fact that there was some research going on may have helped to engender hope. And of course it's true to say, if you don't look, you won't find. So there may have been something there, and it turned out there wasn't, but there might have been something there that would have helped. So conclusions are that suicide and accidents and non-accidental injuries, that's sort of deliberate violence from the staff, were uncommon in this population. Infectious diseases were the predominant cause of death in these young patients, so about 3/5 of the death. So as I said, there is a question of whether these were pre-existing infections or whether they acquired them in hospital. It was probably a bit of both and both together. But the question really is that are patients with mentally ill are they more susceptible to developing infections or more susceptible to die from them? And I think there's some evidence that that is in fact the case, and that evidence is that if you look in developing countries, in Africa and Asia, for example, severely mentally ill people die of infections. And also in refugee populations where care is not good, excess deaths in severe are also driven by excess deaths in infectious diseases. So I think we can probably say that this is actually a marker of what does seem to be a susceptibility for our patients. Why they have that susceptibility is another question, but that seems to be susceptibility. But what I found perhaps most strikingly was this vascular disease of the vessels, heart and brain, prominent cause of death, and the mortality gap is about 15 years. So I want just to spend a couple of minutes just looking at this in the context of the current situation. So now in 2024, we still have patients with severe mental illness, schizophrenia, bipolar disorder, and severe depression have a reduced longevity. And that's about 15 to 20 years. So on average, patients with severe mental illness die 20 years before the normal population. And this phenomenon is found in all these conditions, all the different conditions, the different types of mental illness, but also across all cultures. Different services in different places across the world also found it. So this number is very much a worldwide phenomenon. It seems to be a problem of mental illness, that they die young. And the main cause of death now is cardiovascular illness, particularly in the under 50s where the death rate is quite high. Worryingly, this mortality graph here, I've said it's 15 to 20 years, and if you remember the one I found in Sunnyside was about 12 to 15 years, in Toronto it was about 12 years. It's actually now widened, and it's widened since 2008, since the financial crisis. So since there's less money going into mental health services, that gap has increased. There's basically less care for patients in the community. So it's really quite worrying, that. But really the same phenomenon I found in Sunnyside in 1890 are really still found today. So what's causing this? So one of the causes of this problem, why do mentally ill patients die young? One is that they're thought to be more sedentary, they're not exercising. Now, in these X's and ticks I've said, what's the situation in Sunnyside? Well, that's certainly not the case in Sunnyside. They were very, very active. There have been farm workers and labourers working in domestic service, and when they got into the hospital, they were continuing to have to do that. So they were working hard, they were active for very much part of the day. The other reason mentally ill patients are said to die young is because they're less likely to eat fruit and vegetables. But that didn't apply to our patients in Sunnyside, where the diet was very good. There was fresh fruit and vegetables available from the work on the farm around here. Patients with mental illness are more likely to develop diabetes, and we don't know whether or not that applied to the patients I was studying, because we didn't know about the diagnosis of diabetes then. But what we now know is that patients with mental illness often become obese, and they have 2 or 3 times the rate of obesity that normal populations do. But that's not the case in Sunnyside. The patients were often normal weight or underweight. There were very, very few patients who were overweight, and they were probably underweight because of the mental illness and because they were actually hard working and so on. patients with mental illness nowadays smoke a lot, but they didn't smoke then. Their smoking didn't really take off as a thing for this kind of population until the First World War. But what is the case is in what's so-called inverse care, that patients when they're mentally ill are less likely to report physical symptoms, and that's probably the case then. But what's more worrying is that once they report those physical symptoms, they're less likely to receive optimal care. There's in fact discrimination by health professionals. And I think that very much happened then. I cited the issue of the surgery, which would have saved some of the patients, which wasn't available, and probably others. And then medication, nowadays, it seems to be a big root of the problem, causing people to be sedated and sedentary and obese and so on. But the other patients didn't have medication. They really had very trivial amounts of small sedative medication, but really nothing would cause a problem. So if you then say the problem happened in Sunnyside then and it happens now, but there's a lot of the reasons now are not explained by the past, what is in common are genetic, biological and social factors. And the big elephant in the room is the one I'm going to show now, which is deprivation. And deprivation seems to be a very powerful factor that causes people with mental illness to die young. Whatever deprivation is, and it's a multiple series of disadvantages. So this is fascinating data I don't know if you've seen before, but it shows your chances of dying according to social economic grouping. So along the bottom, in both Glasgow and in Scotland, is the relationship between your the sort of area you live in and your death rate. So you can see the most affluent have a reduced death rate compared with those who live in the most deprived areas. So this curve, and the two curves from the Glasgow data alone and the Scottish data in total, absolutely overlie each other. So there's no doubt that if you live in a deprived area, you're more likely to die young, irrespective of other factors. This death rate is increased. But if you have mental illness, this is enormously exaggerated. So in green here is this same line. So if you live in the most affluent areas, your increase in death rate is much increased compared with the other people living in that affluent area. And it just rises hugely. So if you're living in a very deprived area and have mental illness, your death rate becomes huge. So deprivation, as I say, is multiple disadvantages. Problems with diet, there's problems with recurrent infections, there's problems with not getting proper medical care, and probably stress. And the stress of uncertainty, I think, is a key factor that may lead to you develop problems with longevity in your heart. Now, people often say that deprivation is linked to the so-called deaths of despair, as I told us wasn't St. Valentine's Day, that people dying of overdoses, dying of alcohol excess and so on. But you can see that even if they're excluded, this is still this enormous factor. So this seems to be the elephant in the room. This is the factor that leads patients with mentally ill to get death, this exaggerated effect of deprivation on them. They're even more deprived because they have mental illness, and deprivation seems to have an even bigger effect. And it's thought that recurrent inflammation is a big part of this in a way. And this remains an agenda which Scotland needs to solve, the world needs to solve. What's the cause of this? What's the mechanism? What can be done about it? So my final conclusions are that vascular pathology, particularly cardiac pathology, heart pathology, is common in this young group who didn't die of tuberculosis, and it's a likely contributor to premature death. Most patients weren't obese, they were active, they didn't smoke. So this suggests that the cause of death in that population then was life events, stress, inflammation, are relevant to many silent deaths, and they're probably relevant to current sufferers of severe mental illness. So thank you very much for your attention. I'm very happy to answer questions. Thank you.
Thank you very much. That was fascinating. I will open it up to the floor if anyone has any questions. Straight up.
Hi, thanks very much. It was really interesting. I've got a 26-year professional history of working and being associated with Sunnyside.
All right, okay.
Much of this I didn't know.
I should have mentioned, just remember, I forgot, when it closed in 2011 and it went to Newcastle, they called it the Susan Carnegie Unit, which I thought was a very nice touch. I just remembered, I forgot to say that. I don't know if you worked there or not.
No, but I am the link lecturer. I work in the universities. I head up the mental health nursing programme here. So, I didn't know that. I didn't know that upstairs in the mortuary had been a PM suite either. So, but thanks for that. One of the things that struck me, interested in your response to the question, is that two things seem to coincide around about the time in the history of Sunnyside with these post-mortems. One is the building of the hospital block, which was to the left of the upper part of the main building.
Yes.
My first charge nurse post was in there,
Right.
and there was 2 male wards and 2 female wards. One was a TB ward and one was a so-called male sick and female sick ward.
Yes.
And the gables of those are now incorporated into rather fancy housing in the new estate. Could that have been associated with the fact that this high death rate was going on at that time, or and this high infection rate was perhaps taking place?
Yeah.
And the other is that I have a booklet in my office. In fact, I had 3 of booklets dated 1907. They were actually attendance contracts of employment. I donated one to the Montrose Town Library when I was emptying the offices the hospital retracted. I was doing my Masters in Edinburgh at the time, and I donated one to the reference collection, and I've kept the other one as a teaching guide. And they very much emphasise not browbeating, not striking or physically harming patients, taking records of any injury, and does that reflect perhaps this interest in violence as a possible, although it was not demonstrated in your study, maybe their belief that violence was a factor. I wonder, do both these things conflate with that period of higher levels of post-mortem work?
Right. Well, I think the attendants tend to get a bad name. They were often accused of violence, and it must be very difficult for them to look after disturbed patients without any form of restraint when that wasn't allowed. And we now have chemical cautious, if you like, so it was extremely difficult for them. But I think there was a culture, a very positive culture amongst particularly staff in Sunnyside. It's always had this reputation, I think, of staff of the highest quality. Families used to work there, and of non-violence. And really the violence within the patients was common in my records, but not staff to patients. So I think they had to be vigilant all the time, though. And as I say, in the other hospital I studied, there was a probably definite case of violence of a nurse against the patient when the patient died. But I think these were very rare outcomes. So I think the staff were, in a very difficult situation and managed it extremely well. The hospital block, I think, was to try and allay this death rate because people were dying on the wards, and they thought if we take them there and isolate them, of course there was this issue of isolation. I should have said that they tried their best to reduce the risk of tuberculosis. They nursed tuberculosis patients in the open air, on verandas and so on, wheeled out their beds into the airing courts, as they were called. But the hospital wing was, I think, largely to try and see if they could further reduce the death rate rather than causing it. But often these patients were at death's door and died, even in the hospital wing, when they had more care. So that's my thoughts about the hospital wing. Yeah. Thanks.
The graph that you showed of the Canadian study had separated out by gender.
Yes.
I don't know whether you had a chance to look at that in
yes,
your
I
study.
did. Yeah, I didn't really find very much. The female patients predominated in the asylum. There's a whole interesting story about that there's a kind of part of the history of psychiatry. Researchers believe that women were particularly subjugated and downtrodden, shouldn't have been in the hospital, had become, for example, women who had become pregnant and been taken in, so on and so forth. And most researchers working in this field, and certainly myself, didn't find anything of that sort at all. The female patients seemed to have as much mental illness as the men did. There were slightly more of them, but not anything different. And there was no particular difference in death rates or causes of death between male and female, or really between mania and melancholia. So I didn't really find differences, which I obviously looked for because I thought those might be interesting clues, if you like, but I didn't find any male-female difference in death rates or in causes of death. Sure.
Thank you very much, Nicol. That was very interesting. What are your suggested hypotheses as to why there was an increased death of cardiovascular disease in Sunnyside, where they were physically working, eating fresh fruit and vegetables? Why was there still?
Well, that's a really, the million-dollar question. Why is this occurring? What are the links to atheroma? And there is quite a lot of data that chronic stress, chronic adversity, is associated with atheroma. And it's particularly the issue of sort of chronic uncertainty, of not knowing. And I think if you have mental illness, anytime you're feeling extremely uncertain about your future, your family's future, and that was amplified in those days because many of these men, for example, would be breadwinners, and then they become ill. The whole family is becomes very distressed as a result of that. So I think these stressful things do seem to be associated with the development of atheroma. That's one aspect of it. The other aspect is that I just mentioned it in passing, but genetic factors do seem to be important. And more modern research has been looking at large populations of people with mental illness and large populations of people who have vascular disease, and finding some genes in common between the two. So there may be some genes that make you more prone to develop vascular disease and mental illness. Now, they've not got very strong signals at the moment, but that's quite difficult to refine and define, I think. But I gather those working people feel very optimistic that they will actually be able to identify vulnerability genes that seem to be associated with both conditions. So that's the other factor. But why do people in deprived populations die of heart disease? I mean, Scotland is very much well aware of this problem. Sir Harry Burns has been trying to work on it for 20 years now, and we don't know the answer to that question. So, well, the answer to that question is probably the answer to your question, I think. I think. Sorry. Hello, yes. Yeah.
Other than the garden, how were they occupied? And were any of them just kept in beds all the time as hospital patients?
Yeah, well, bed rest was pretty much frowned on, except when they became extremely emaciated. Some patients became emaciated, so bed rest was then encouraged. But apart from that, the patients were very much on parade, had to get up and do their duties in the garden. And it was seen, as their duty, but also, their treatment as well. So they were very active for much of the day. They tended to be very sexist about this. The women were in the laundry, cleaning the place, and the men were out working in the fields. That was a stereotype. It wasn't exactly like that, but it had that feel about it. So it was very much absolutely predetermined that should be the case. And people like Susan Carnegie and Brown and these other reformers all felt this was very important. And I guess we still feel that today, that engaging someone in activity is a really very good diversion therapy. It's also very good therapy for their mental illness. I don't know whether they were overworked or not. I couldn't say. I don't know. Possibly. I don't know. But they also had lots of diversions. They had these entertainments, particularly in Sunnyside, concerts. Virtually every night they would have a band playing. They had dances as well. And there's, in the middle of Sunnyside, you may have seen this, there's this huge ballroom, which is a fantastic place. There's a wonderful floor, and it's got a stage as well with some wonderful pictures behind it. And so dances were encouraged. What the dances were like, I couldn't say. I mean, it does sound quite a prospect to have that large number of mentally ill people dancing in the Scottish Highland dancing is quite a thought, but they did have frequent dancing. And of course, religious education was very important. So there were services every Sunday and services several times during the week. Scripture was very much seen as another way forward for these poor patients. Hello. Hi.
As in moved to Montrose
Yes.
to receive care in the community
Yeah.
after having a pretty settled existence
Yes.
in Sunnyside, with all the support services,
Yeah.
which in my opinion disappeared for a lot of people.
Absolutely, yeah. I mean, I think that's a particularly difficult population, the one who've kind of got used to being in the asylum, the so-called institutionalisation, and then moving out is really very stressful. And we know that that's been in the past when we had people in institutions for long periods. That was a real problem. But nowadays, what should be happening is short admissions and people being admitted to care in the community. And I have to say, it's just not happening. It's very sad for me at the end of my psychiatric career to see this. You know, in the past, people were looked after by the hospital and passed over gradually and slowly. There was rehabilitation. There was all sorts of support packages put in place for people. And really, to be honest, none of it happens now. So I think this is why this death rate is increasing. I think it's to the lack of community care. I mean, I'm stressing I think. I mean, I can't prove that. But it seems very likely to me that's the problem. These patients, once they're out of an acute care in the hospital, they get lost. And they just simply, they start not doing anything. They sit at home watching the telly, eating and drinking too much, smoking, and you know that leads to them becoming iller, in fact, and probably dying even younger. And that's what seems to be happening. So I'm really very distressed and upset at the lack of care in the community. I think Scotland's better than it is in England, but that's another long story which we don't have time for. That's my thought about that.
I think we'll call this evening to a close. If everyone could join me in thanking Nicol again, that was.